Good afternoon, and welcome to Building a Resilient Food Culture, Lessons from the Pandemic. This five-part series of monthly webinars is designed to examine what we have learned about our food system and our food culture in the ongoing course of the current crisis, and how these lessons might be applied to ensure a better future for all. I'm Lisa Scales, President and CEO of Greater Pittsburgh Community Food Bank, and will moderate today's discussion of the interrelated issues of health, nutrition, and race. In the creation and sponsorship of this series, the Food Bank is delighted to work with our colleagues at Food 21 and the University of Pittsburgh Honors College. For this first session, we have recruited a panel of experts in medicine, food history, nutrition, and health equity, and have asked each to provide their perspective and insights on the challenges posed by the coronavirus and the opportunities to apply this experience as we look forward to a post-pandemic food system. You should have received biographical information on our panelists. So in the interest of maximizing our discussion time and what I hope will be a robust question and answer period, I will assume that you know how fitting it is that they were asked to join us today and how grateful we are that they are willing to share their time and experience with us. Throughout the session, please enter your questions into the Q&A feature, and we will attempt to get as many of them as possible after hearing from our panelists. And now it's my pleasure to introduce today's panel. First, Dr. Julia Hudson Richards, a food historian who earned her PhD from the University of Arizona. She is an instructor with the Department of History at the University of Pittsburgh and co-authored the paper on coronavirus, food, and inequality. And she will share with you, and this paper has been shared with you prior to this webinar. Next, we will hear from Mim Seidel, Chatham University's Assistant Professor of Nutrition and co-chair of the Pittsburgh Food Policy Council Steering Committee. Mim is a registered dietitian with expertise in public health nutrition, food security, translational research, program planning, and development. Our final panelist is Dr. Utebe Essien, Assistant Professor at the Pitt School of Medicine, General Internist, and Health Disparities Researcher for the VA's Center for Health Equity Research and Promotion. Dr. Essien was recently named among the top 50 experts to trust during a pandemic by Medium Magazine. Thank you all again for being here today. We will start with Dr. Hudson Richards.
Lisa, very quickly, thanks again for that great introduction, and I want to thank everybody who took time out of their and presumably incredibly busy schedules to join us today. I've been working on this for most of the year with Food 21, but when we first started talking about food inequality in the greater Allegheny County area, we had no idea that we would be facing down a genuine food security crisis, really within a month of our earliest meetings. And when I started to work on our first paper with Brooke and with Corey Flynn, we realized we had this really unique opportunity to be part of, at least making suggestions on how to make our food system more adequate, more responsive, and more equitable. As Lisa noted, I'm a historian. My areas of expertise are food history, but also the history of inequalities and movements to rectify those deep-seated social inequalities that still continue to plague us. My job here today is to provide some contemporary and historical context for the work of the two really tremendous guests that have joined us today. So without further ado, I'm going to jump right in. Obviously, most of you have day-to-day experience with the realities of food insecurity. And though the term doesn't appear until after World War II, sometimes well after World War II, the concept of food inequality has always existed, but it looked very different 1,000 years ago when everybody grew their own food than it does, of course, today. Our modern food insecurity is directly related to the expansion of a global market in food that's worth trillions of dollars. And yet the people who pick and produce and service our food and sell us our food are more likely to need food assistance. The food assistance that people need is often depicted as some sort of personal failing rather than a systemic weakness. And when I teach my history of food class, students are often quite shocked to find out that food insecurity, but also even things like food shortages and famines are far more related in the modern era to the system of food distribution and ideologies and policies around food, rather than any actual environmental or food production shortage. Now, since the foundation of the Food and Agriculture Organization, UN member nations have collectively agreed to work together to end world hunger. And by the mid 2000s, we had made huge strides in that respect. In the United States, food insecurity for the last part of the 20th century and the first decade of the 21st remained relatively stable, spiking as a result of the Great Recession when it reached a high of 14.9%. Now, we didn't achieve pre-recession levels of between 11 and 12% again until 2018, which really highlights that economic shift that was inherent in the slow recovery from that Great Recession. So what does that look like then? If 11 to 12% of households are food insecure on a regular basis? Well, in 2019, the food insecurity rate was 11.5. The United States had 122.8 million households, which meant that 14,122,000 households were food insecure at some point in 2019. That's 35.5 million people. But we have to zoom in on these statistics because they miss a lot of the detail. Now, researchers note first that it is notoriously difficult to assess food insecurity in Native communities, particularly on reservations, because federal provision of food has frequently been inadequate and often not the most nutritious food. And also because reservation systems themselves fractured the traditional food provision networks, hunting, as well as communal growing that had existed prior to the reservation system. In addition, because the data frequently tracks households rather than individuals, the homeless population is often excluded from that data. Now, secondly, the deep-seated racial inequality that has continued to plague the United States is also reflected in food insecurity data, as you all know. Black Americans experience more than twice the rate of food insecurity as white Americans, and Hispanic Americans experience 1.5 times the rate of food insecurity. Outside of major urban areas, they're also more likely to live in food deserts and have less reliable access to transportation, particularly public transportation. But the statistical data on inequality even these points don't give us a real picture of food injustice in the United States. With data being self-reported, your own interpretation or perception of your food security and your diet is a significant factor. And while you may not experience hunger, low food security generally indicates a lack of quality food, a variability of diet, and satisfaction with your diet as well. The adage that healthy food is expensive doesn't mean that each vegetable is more expensive than a box of mac and cheese, but rather that incorporating fresh fruits and vegetables regularly into your diet needs refrigeration, it needs access, and there's a marked difference in the quality of produce from one area to another. And I witnessed this firsthand as I moved into our new place in the North Hills. I live in sort of roughly equidistant between two giant Eagle supermarkets. One of them is in a more modest area and one is in a much more affluent area. And I've personally noticed significant differences in the quality, variety, and amount of produce at each of these stores. And only one of them is accessible via public transportation. I'll let you figure out which one. If your food rots before you have a chance to eat it, it's expensive no matter how much you actually paid for it. I also don't have the same adequate access to leaner meats at one of the stores as I do at the other. So all of this means together that when people make food choices, they can only buy what's there. They may not want to take risk on produce that's going to go bad before they have a chance to eat it. And it makes it more likely that they will have to choose a product that provides a caloric bang for their buck, filling, cheap, shelf stable, and often ultra processed, which I know Dr. Seidel is going to get into. Now, I'm not here to slam processed foods in general. They've become a bit of a boogeyman. Most of our food is processed in some way, and our modern economy cannot exist the way it does without processed foods. But I do want to highlight the inadequacy of our current food provision system. Food insecurity is one of the biggest public health challenges that we face, and it is directly tied to the health of our economy and the systemic racial, but also gender and age bias that we deal with on a regular basis. Now, the other area that the data cannot really represent, but the one we saw fully on display during the COVID-19 shutdowns, particularly early on, is that not being classified as food insecure does not mean you don't live on its edge. Historically, as I tell my students, most people lived on the edge of subsistence anyway. And we really didn't begin to move away from this on a sort of global scale until the 19th century, but that happened very unevenly and very unequally. But as we saw beginning in March, the fact that most Americans don't have a savings and don't have good access to credit means that when things began to shut down, people went from food secure to insecure very, very quickly, sometimes within just a week or two. Our emergency food system was completely overwhelmed. Stories appeared, of course, in major newspapers and media outlets about long lines and shortages, and people stepped up and helped. It was really awesome to see. Every day we saw donations to food banks, but also pop-up pantries on porches and in church basements. It really, if you study food insecurity, it was the kind of thing that brought tears to your eyes. But it didn't change the fact that despite indications of a strong economy in 2019, record high stock markets, low unemployment rate, high rates of consumer confidence, lots and lots of families live paycheck to paycheck, even higher earning families. And when economic crisis struck, they were incredibly vulnerable to its effects. Now, as we move into the winter, it's possible, maybe even likely, that we will see an increase in this economic vulnerability that has food at its center. We have become really dependent on imports from Latin America for fresh fruit and vegetables. And Latin America has been dealing with COVID outbreaks as well. If we have this predicted second spike, second wave, third wave of infection, further shutdowns of stores and restaurants and bars could throw Americans right back into additional crisis. We are also seeing increased rates of COVID infection in rural areas that had maybe avoided a lot of it in the summer. And they tend to have higher proportions of food deserts, less consistently locally based food provision, and worse public transportation. Now, our current food insecurity data, and I'm going to share my screen very quickly so we can take a look at our current numbers, just was released by Feeding America, and it shows that we really aren't getting out of this anytime soon. Despite expanded provision of food through programs like Farms to Families, in Allegheny County, we still saw a 57% increase in food insecurity with families with children, and a 42% increase in food insecurity for families without children. These are significant increases. So we're looking at already a 5.5% jump in real numbers. What this means, though, in terms of large-scale inequalities, it was broken down by Northwestern University's Institute for Policy Research. According to a June study, when you break down those national inequality, food insecurity numbers, according to demographics, we see that Black households with children are reporting a 41% rate of food insecurity. And that's up from a national average of about 20%. So Hispanic households with children reporting a 36% rate of food insecurity, while white households are reporting an increased rate of 24%. These numbers are incredibly concerning, particularly if you take into account that COVID-19 has already had a disproportionate effect on communities of color in the United States. According to the CDC, Black Americans are 2.6 times more likely to die of COVID-19 infections, and Hispanic Americans are 2.8 times more likely to die. But the most sobering statistic that was just released by the CDC shows that the increase in poor outcomes for children infected with SARS-CoV-2 disproportionately affect children of color. 78% of children who have died of COVID-19 have been Black, Hispanic, or Native American. And COVID-19, on the one hand, then has presented a host of challenges and made these inequalities impossible to ignore by all but the most determined to do so. But moving forward, we also have a tremendous opportunity to genuinely reform our food system to make it more equitable, more responsive to crisis, and of course, more nutritious for everybody. Thank you.
Thank you so much. And we'll now turn to Mim Seidel. Mim.
All right, thank you, Lisa. And Sam, if you could start the slides. And I'm happy to build on what you just heard from Dr. Hudson Richards and give you comments from a nutritionist perspective. And if you could go to the next slide, Sam. Most people, of course, are dismayed to imagine anyone not having enough food to eat, to imagine an adult or child going to bed hungry or limiting themselves to just one type of food for the last couple days out of the month when the money runs out. And when we talk about food insecurity, and the definition from the USDA is limited or uncertain availability of nutritionally adequate and safe food, or also another definition is limited or uncertain availability to acquire culturally appropriate food in socially acceptable ways. We can understand that food insecurity is much more than just periodic discomfort, but can lead to long-term consequences. And that is what I want to talk about today. So what you have in front of you are pictures of nutrient-dense foods. US dietary guidance recommends that we eat a variety of wholesome foods daily that give us the equivalent of 5 cups of fruits and vegetables a day, many servings of grains, half of which should be whole grain, lean meats if you eat meat, nuts, beans, legumes, dairy products or dairy product substitutes that provide calcium and vitamin D. Now, why these foods are called nutrient dense is because the ratio of the nutrients to the calories, that's how you get nutrient density. So you've got a lot of nutrients, vitamins, minerals, protein for the amount of calories. You know, for 25 calories worth of carrots, I can meet my entire recommended dietary allowance for vitamin A. So that's a nutrient dense food. Nutrient-dense foods are often perishable, as we heard, and they often require more preparation than calorically dense food. And let me also make a comment when we talk about nutrient-dense foods. My comments in no way indicate that there is one eating pattern that is nutritionally better than another. In other words, people make different food choices based on their culture and their preferences. Different ways of eating can support health. There's no one perfect way. But no matter what one's food culture is, if a family is forced to choose foods because they are cheap and filling and must forego foods that are nutrient dense, then we're going to run into trouble. Next slide, please, Sam. So calorically dense foods, by definition, are ones that are packed with calories per serving size, but often have minimal amounts of important vitamins and minerals. These foods usually cost less per calorie than the nutrient-dense foods. They're often shelf-stable. They may be what we consider ultra-processed foods. Ultra-processed foods have been gaining a lot of interest from the health community. They are defined as formulations of food substances, often modified by chemical process, and then assembled into ready to consume highly palatable food and drink products using flavors and colors and emulsifiers and other additives to make them taste good. These foods are usually high in sodium and or high in fat and or high in sugar, an unholy trinity of processed foods. Studies have shown a positive association between the household's availability of ultra-processed foods and obesity in that household. Also an association with an eating pattern that's low in fiber, protein, and potassium. And potassium is an important mineral that helps control blood pressure, among other things. I hope it's clear that the reason I'm stressing the calorically dense foods are cheaper than nutrient dense foods is because if you're food insecure and you're trying to fill your family's bellies with limited resources, it makes perfect sense to head to the foods that give you more calories for the dollar. Next slide, please. So one more point before I get specifically into physical and emotional consequences of food insecurity. Let's remember that not all low-income people meet the definition of food insecurity, but we do know that low-income people, compared to higher-income people, often obtain, for a variety of reasons, a lesser amount of key vitamins and minerals from their diets. So, quick nutrition lesson here. The RDA, recommended dietary allowances, are the amounts of nutrients that meet the needs of 98% of healthy adults in our country. Deficiency diseases develop only after a very low intake of a vitamin or mineral. However, where to draw the line for optimal health is still being studied. So with that in mind, if we know a population is meeting less than 70% of the RDA for a variety of vitamins and minerals, or that they are considered to have an inadequate intake of a vitamin or mineral, it's a red flag as far as health goes. What this slide is showing you is the vitamins and minerals that are of lower intake in low income individuals. And on the other side, you're seeing the vitamins and minerals that seem to be important to support our immune system. The strongest evidence of immune support are from vitamins C, D, and zinc. And you notice that they end up on the side of possibly problematic intake for low-income people. So think of COVID-19 and think about how important a well-functioning immune system is. Think about getting who's sickest from the disease, and we may have the beginnings of some information here where we can put 2 and 2 together. If we could go to the next slide, please. All right, so now I want to specifically talk about food insecurity and adverse health outcomes in children. So when we look at food insecure children, we see that there's a positive association with hospitalizations of these children since birth. And the more severe the food insecurity in that household, the greater the chance that that child is rated as having a fair or poor health status. Food insecurity is positively associated with iron deficiency anemia in 6-month to 36-month-old children. Iron deficiency anemia causes irritability, fussiness, fatigue, fast heartbeat, sore tongue, and other things. A child with this type of anemia will often engage less with their surroundings, and they thus have less opportunity to socialize and to learn. Food insecure preschoolers are found to exhibit behavioral problems like aggressiveness, anxiety, depression, inactivity, or inattention, and hyperactivity. And that creates struggles and possible failure in school, which of course has long-term consequences. And finally, food insecurity in a household is positively associated with parental reports of the child having developmental delays. Next slide, please. So if we're looking at food insecurity and adverse health outcomes in pregnant women and moms, we see that food insecurity is positively associated with psychosocial indicators of perceived stress, depressive symptoms, anxiety in the pregnant woman. And the greater the greater effects are seen if we have more severe levels of food insecurity. And women who are stressed like this or depressed are more likely to smoke, drink, or otherwise not take care of themselves during pregnancy. Food insecurity is also associated with maternal personality disorder, and that is associated with reductions or loss of welfare benefits and SNAP benefits because the woman is not keeping up with what she needs to do to get these benefits. Also, of much concern, food insecurity is positively associated with low birth weight babies. And as you may know, if a baby is born at low birth weight, there may be developmental delays, learning delays, there may be physical defects that do not get better. This is a lifelong consequence. And food insecurity is negatively associated with the initiation of breastfeeding. And if breastfeeding is initiated, the duration is lower. And given the fact of not just the nutrients, but the immunoglobulins that are passed in breast milk and help the developing immune system of the baby develop in the best way, this is of grave concern. Last slide, please. So while short-term food insecurity is more likely to cause, which is what you might argue is what the pandemic is doing, it's more likely to cause a transient stress and not the long-term consequences that we noted here, the results of this pandemic are going to be long-term for many groups. The economy is not going to recover just like that. And, we can't go back to normal. As normal has included, as we just heard, the pre-pandemic normal has had many people with food insecurity for far too long. And finally, we need to create systems that support the right of all people to healthy and culturally appropriate foods. Thank you.
Well, thank you so much, Professor Seidel. And we'll move on now. And Dr. Essien, we'd like to hear from you.
Sure, I'm going to pull up my slides here and thank my fellow panelists for their wonderful presentations. And I think we've heard a lot about the pandemic and its impact on our society and kind of why we are having this discussion at all, specifically focusing on health, nutrition, and race. And so I'll try to kind of bring it full circle into why this conversation is so important for this moment. And so as I've been thinking about the COVID-19 pandemic as a health disparities researcher, as a physician, as a Black man in this country, these are kind of the three threads that I've been really thinking through. The data related to disparities in COVID-19, which my fellow panelists have alluded to, some of the drivers of the disparities that we're seeing, and lastly, trying to identify solutions, especially again within our focus today around food insecurity and nutrition. And so again, I'll kind of briefly run through the data because I know that we've seen a lot of it. I always like to start my conversations around food and or health inequities, with this quote from Dr. King, which I think is very familiar and says of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I think that that is a good kind of template as we and framework for this conversation that we're having overall. Again, when I think about the health inequities in the country as a whole, I do think it's so critical to bring ourselves back into our local environment and what's happening in our communities here in Allegheny County, in Pittsburgh, more specifically. These are data that were published out last year, examining life expectancy in our city. And you can see that while the really alarming numbers in terms of difference in life expectancy by race and gender in our country are quite, or in our city rather, are quite stark. The fact of the matter is, whether I showed you a map of Boston where I trained or New York City where I grew up, these numbers would really be strikingly similar. And it's really with that many of us who are working in the health equity space were not really too surprised, unfortunately, to see headlines like the ones on your screen right now that have really made up the last 7 months of the pandemic, really highlighting that Black Americans in particular were being infected, being hospitalized, and dying at far higher rates from their non-Black counterparts. As the headlines continued on throughout the pandemic, we quickly learned that this was not just a Black and white issue, but that individuals in the Latinx community, as well as those in the American Indian community or Indigenous Americans, were also facing high rates of COVID-19 mortality and morbidity. Again, because I think it's so critical to bring the data back within our environment, you can see probably a website that many of us are all too familiar with, our Allegheny County data, looking at the cases and deaths related to COVID-19. And you can see I highlighted specifically Black cases here, showing that despite Black Americans making up only 13.5% or so of our overall population in Allegheny County, they were making up 23.5% of the cases, these data being shown from about a week ago. We've also seen that here in our county, the hospitalization rate has been really starkly rising among Black Americans. And you can see that specifically from the start of the pandemic, where we've really been fortunate in our community to not have had the same rates of COVID-19 that many of our colleagues and citizens, fellow citizens, are having outside of Allegheny County. That once the cases did start to rise, unfortunately, we were seeing very similar disparities to what were being reported across the nation. And so why is that? Why were these disparities so stark and so significant? I like to think about this framework as our country has been thinking about health inequities and has really been ramping up its attention to the area of health disparities and inequities. And so starting with the risk factors for COVID-19, starting with the differences in access to care, challenges in missed care over the last 7 months, and lastly, ending with a conversation around the post-COVID-19 era and what that era looks like, as Miriam just mentioned in her remarks, so that we don't return to the old normal, so to speak. And so as we were first getting results out of China and Italy, when they were first experiencing COVID-19, some of the key risk factors that were being associated with severe infection with this new virus were some of the ones that have been discussed already: high blood pressure, diabetes, other cardiovascular diseases. We know, as my fellow panelists have discussed, that these are diseases associated with healthier diets and with the ability to afford healthy foods. We also know that unfortunately these chronic conditions and pre-existing conditions have been more likely seen in racial and ethnic minority groups, who are represented in the red bars on your screen there, having higher rates of high blood pressure, diabetes, and other risk factors for COVID-19. We also know that there are far more social risk factors that have been associated with high rates of exposure to COVID-19, whether it's the ability for an individual to work from home, as many of us are doing today, or they have to go in for their regular jobs as essential workers. And you can see on your screen here that several studies have looked at this case and saw that certain racial and ethnic minority groups were more likely to work in various positions such as home health care and public transportation and even in food services, without really that ability to shelter in place and protect themselves by working from home during the pandemic. The environment is another huge important risk factor for us to be thinking about, especially within our system. Where are the homes and houses that not only expose individuals to poor air, but as was mentioned by our first panelist, also expose individuals to lower access to healthier foods. And again, that cycle resulting in higher rates of chronic diseases and higher rates of COVID-19 exposure. In the access to care leg of this framework, really the big driver is thinking about insurance rates. And some of the first calls at the start of the pandemic were advising our patients to ask your doctor about your symptoms. Well, we can only imagine what that ask looked like if an individual didn't have the insurance to be able to actually speak with their physician or their care provider. And we can see from some of these data from published 2 years ago that those who are uninsured in our country, the 27 million Americans, tend to come from racial and ethnic minority groups. Again, moving along in our framework and thinking about missed care, I want to draw attention to the fact that over the last 7 months, we've seen really sharp reductions in kind of the typical hospital admissions. There have been fewer folks coming in with heart attacks, fewer individuals coming in with strokes. And it's not just that those diseases disappeared, as we can imagine. People are still sick, and not only just from COVID-19, but from non-COVID related diseases. But there's really been a challenge over the last 6 months with engaging with our patients outside of the health system, the typical format, as we've now been asking our patients to depend on potentially unreliable internet service or broadband internet. Again, challenges that they've had with not just accessing their food or their typical resources, but also with accessing their healthcare as well. And again, this digital divide, unfortunately, really carries across a racial divide as well. And so lastly, just wanted to quickly touch on the post-COVID-19 era. And when I think about this era, I do largely think about the social determinants of health, many of which we've spent the last 30 minutes or so describing. And we see that from economic stability to the neighborhood our patients live in, all the way through to education, that really these are not just the things that have been driving severe infection with COVID-19, but also are the pieces that we, as a health system, as public health leaders, and as policymakers, need to consider to be thinking about how do we address quickly and urgently so that the post-COVID-19 era is not as impacted in the way that we've been impacted during the pandemic. And so just wanted to touch on three key areas of social determinants in my closing remarks before we move on to what I hope will be a robust Q&A session. The first one being employment. We quickly saw at the start of the pandemic, not just those huge lines at the various food banks, but we also saw huge lines at the unemployment offices, and virtually or in person, we saw millions of Americans start to lose their jobs. In our country, employment is so closely linked with insurance. And I've already kind of shared just how critical insurance is to be able to just gain access to healthcare in our country. Next, obviously, the topic of conversation at hand today is food insecurity. And again, I've had our colleagues already share with us just the severe challenges, not 3 weeks, not 1 month, not months into the pandemic, but literally week one, we saw individuals start to really realize just how tenuous their access to food was. And I'm really looking forward to an ongoing discussion about how we can try to really move forward so that we are not exposing so many of our fellow citizens to these significant rates of hunger in our country. And so I mentioned just thinking through a few strategies on how to address some of the disparities that we're seeing in COVID-19. I'll just lay them out very quickly and very broadly so that we can get into the meat of our conversation today. We need more data related to race and ethnicity in COVID-19. We need to be able to expand access to healthcare in our country. Obviously, increasing testing and tracing and treatment for folks with COVID-19. The main part of our discussion today, or a main part of it, is thinking about how racism and discrimination really ties and intersects into health and nutrition. And this is a national conversation that we're having right now, more robust than ever before in my lifetime, and speaking to my mentors and parents and older patients in their lifetimes as well, and really hoping that this culture that we're having around open discussions around race and racism can help us move the conversation forward. And lastly, really, I'm thinking about elevating community and social service investments. And again, that obviously focuses on food insecurity in our conversation today, and ensuring that everyone within our community has access to healthy foods, but also thinking outside of the box with some additional resources that we as health providers can help provide. We can engage with dietitians, with policymakers, public health officials around our country to help support. And so I'll leave with that and have us hopefully join again in hearing your questions and what other comments you may have. Thanks so much for your time.
Well, thank you, Dr. Essien. And before we get to the Q&A, I really want to thank each and every one of the panelists for your insightful and thought-provoking presentations. And this really serves as a wake-up call for this is a crisis situation. And really is a call to action to us and to the community at large. And you've really spelled out the impact of the inequality in our systems and how we must do better so that everyone has sufficient food to eat to live healthy, active lives. With that, I know we are starting to line up some questions in the Q&A. And the first one is from Darlene. And Darlene, thank you so much for your question. I know your work well. You do great work on the North Side. And thank you so much for everything you and your colleagues on the North Side are doing. You do have a question about needing some assistance with locating health statistics on residency by zip code. And you're focused, I know, on the zip codes in the service area on the North Side. And you said since March, you've been offering first quality, reliable, fresh produce 3 times a week with no limitations on how often your clients receive the food. So thank you for that. But you say you need longitudinal research project on comparing produce availability to health. Which of our panelists would like to take that on? Can anyone help them on the North Side have some of those statistics?
I haven't seen any, and I spent probably about a total of 10 to 15 hours looking over the last couple of months at zip code specific data, and I haven't seen a lot of that, to be honest. And I do know that Food 21 and the University of Pittsburgh are working together to put a food abundance index tool into people's hands that might help gather that data. And maybe we can chat for just a brief minute after to talk about the introduction of this tool, which our forthcoming paper on food inequality will be addressing. And it looked like you also asked about longitudinal research projects. Now that sounds like something that could be organized among upper level public health or master's level public health students, upper level research students, maybe through the Honors College as well. So I think that there is an opportunity here to collaborate with the University of Pittsburgh and maybe with Chatham as well. So that I would say maybe reach out to one of us. You should have emails. Did we give out emails? And to see who you might be able to be put in touch with that. But that looks like a really fascinating research project.
Yes, it does. Thank you. Thanks so much. Darlene followed up with another question about increasing the amount of fresh, first quality produce at their food pantries. And I can tell you, Darlene, that at the food bank, we're committed to continuing to distribute fresh produce that is good quality. It's now 35% of our distribution. Last year, we distributed 12 million pounds. And our goal is that fresh produce will be 50% of our distribution, or 20 million pounds a year. So for anyone who's in our network, know that that's our commitment to the community, is that we are going to continue to provide fresh, healthy, nutritious food to our pantry network. So continue to access the Northside Food Pantry, and I know that they get fresh produce from us. But you also, that data is so important in terms of that connection between good nutrition and health, and that can really help you raise money for fresh produce. And Professor Seidel, I don't know if you want to just talk a little bit about, again, that connection and how a food pantry can use that information to help raise money for more fresh food.
Right. So you know, in the past, food banks, food pantries were mainly offering shelf-stable food, and which was often high in sodium, could have been high in fat, but often high in sodium. And so very happy that the Greater Pittsburgh Community Food Bank, as well as other food banks, are making a great effort to have fresh fruits and vegetables available. We talked about the different nutrients that help support the immune system, and many of them are found in these fresh fruits and vegetables, and people like fruits and vegetables. However, you know, as you were talking, I was thinking, I was getting this vision of people going to some of the produce pickups, the produce to people, to a pantry and getting produce. It weighs more than other food. And if you're walking, if you're elderly, there becomes a challenge that needs to be addressed of how to help people get this food home. And then we also have the challenge, and this goes into social determinants of health and all the other disparities that we see. Does my refrigerator work? Does it hold the temperature? So now I got a lot of produce and I want to put it in my refrigerator because I'm not going to eat it all today. But my refrigerator doesn't keep at 40 degrees, you know, or I did a program at a WIC office and we were talking about the farmer's market, and there were people who didn't have cutting boards and people who didn't have good knives. And that makes it harder to eat, to use the wonderful produce. So I think what I'd like to say to this, I am so happy more produce is being available, but I would like pantries and other organizations to think about how they can decrease barriers to the use, to the picking up and the use of this produce.
If I could sort of piggyback onto that, because I think Dr. Seidel, you make a really tremendous point. And it's one that doesn't get, I think, emphasized enough, that it isn't just access to healthy foods. I mean, you talked about, whether is your refrigerator working? Do you have electricity currently on in your home? the access to not just cutting boards and knives, but things to cook with, pots and pans, and is your gas on? All of these things are part and parcel to that, and create additional stress, which creates cortisol, which increases the risk of obesity and all of these other diseases as well. So all of this is part and parcel to this economic inequality that we see, hovering around food. And food is this amazing hub that all of these different spokes shoot out of. And so, I know that, the Wilkinsburg Free Store, they have access to things like that. But every community, if you have a food bank, should be able to tell people where they can go to get high quality, or not necessarily high quality, but good used stuff. Not just they can buy it, but is there a place where you can get it for free? If you have stuff, instead of throwing it away, donate it to a food bank or to some place that can distribute these things a little bit more easily. They can be heavy too. So, making sure that people have access to those things, I think we take it for granted in many ways.
No, I really appreciate all those comments. You're right. Access alone, you need access, but then there's so many other issues that people are struggling with that may prevent them from actually being able to use the food that they get, if they can even get it. I do have a note here in the chat from the Pittsburgh Food Policy Council is preparing to launch a food map of Pittsburgh, which includes access and food quality indexes. And Emily Schmidlap at the Food Trust can also offer some information on Pittsburgh region produce data. So just want to point that out to check out the chat, and there's some additional information there. We do have a question moving on, very related to what we were just talking about. I'm not sure if there's more to elaborate on, but there was a question about seniors not being able to physically go to a food pantry to get the food, and also to get good nutritional, to get the information as well on nutrition and what foods are best to eat. It may not be safe for them to go to a food pantry or a grocery store. And so those challenges that we know the seniors are facing. Any of the panelists do you have any data specific to seniors that you could share with us?
I can just start and say more broadly related to the technology aspect of that question. I think we need to give our older fellow citizens a little bit of credit around their technology access. I think more and more data are showing they are more adept than we think. I think one of our colleagues are just sharing about their older father rather, being on a Zoom call a couple of weeks ago. And so I think giving them that benefit of the doubt. I work in the VA, where we've been leading telemedicine efforts for years now, before the rest of the country really picked up during the pandemic. And a large majority of our veterans are older and really engaged in this video format. So I think really thinking thoughtfully about how we transition some of these resources to a virtual platform to engage with them is useful. Unfortunately, we continue to see that our older citizens are really dying at disproportionately higher rates from COVID-19. And so just thinking again within the broad framework of the pandemic and its health impacts and food impacts, how do we keep that population as safe as possible while getting them the information that they need is really going to be critical. So I think that we can do it if we really start to continue to think about how to creatively do so.
Thank you for that. We have a question about policy and how we can help drive a policy change agenda to more permanently expand food and health equity. Thoughts on that?
Well, I'd like to give a shout out to the Food Policy Council, who has worked for the last 2 years on creating a Greater Pittsburgh Food Action Plan. And in that plan includes policy pieces of looking at local government and at funding sources to push forward policies that will help people access food, to create to support SNAP, so on the state and federal level, to provide advocacy for programs that support people like SNAP and like WIC, and the minimum wage. Let's think about that. If we can increase the minimum wage to a living wage, which everybody talks about $15 an hour, but it's probably a little more than 15 at this point. But even $15 an hour compared to $7.25 an hour, and jobs with health insurance, we start addressing those social determinants of health in a really impactful way. So how can people do that? Think about who you vote for. Write letters to those people telling them what you support. If you want to get involved with the Greater Pittsburgh, with the Food Policy Council, Pittsburgh Food Policy Council, I'll put the address in the chat. And I know that Greater Pittsburgh Community Food Bank has advocacy, and you do good advocacy to support people who are food insecure.
Thank you for that, Mem. There is, let's see, a question about the food insecurity and the public health inequities. If we can join those together, is there data that's unique to Pittsburgh? Do we have data that's unique to Pittsburgh or to Southwestern Pennsylvania that we can prioritize? I see a lot of national, I'll just comment to see, we see a lot of national data on the link between health inequality and food insecurity, but do we have Pittsburgh data?
In terms of health inequality, air quality has been a significant indicator of poor health, and particularly in areas, low-income areas, lead still in water. But in terms of food insecurity specifically, expansion of public transportation. I've seen a lot of comments in both about the difficulty in gaining access to food. And I've lived in places with better and cheaper public transportation. And when you have that, you might be able to go to the store every day or every other day. And that's something that's much more difficult to do when when it takes, a 2-hour round trip to go to the store. Or there was a great comment about the redemption rate at farmers markets. Well, the availability of those things doesn't always conform to work schedules, especially if you have to, work in the evening, or if you work an inconsistent schedule. So, being able to look specifically at work patterns in the greater Pittsburgh area, I think would give a lot of great data here on how people access their food, because that is a food security issue as well. It's not just, can I buy food, is when do I buy food? And, do I have to get it at a convenience store because that's what's open?
Right. Dr. Essien, do you have anything to add to this?
Yeah, I was going to say the data that Dr. Hudson Richards showed earlier related to food insecurity in Pittsburgh, I think is tracked so well with the data that I reported in my slides from the Gender Equity Commission that the mayor's office out of Pittsburgh put out last year around some of both the life expectancy, which I showed, as well as the other chronic disease inequities that we're seeing by race and ethnicity. And so to see that 40%, at least nationally, 40% of Black individuals are food insecure, and to see that difference in cardiovascular death and life expectancy, I think it tracks really closely. But I do believe, like the question asker said, that there are opportunities for us to really dive deeper, whether it's looking at zip code level data, looking at where our patients receive their care. One of the biggest challenges that we've had as public health researchers is not actually, and providers, not actually collecting information around food insecurity in the hospital. So the kind of mantra for decades has been, well, what can we do about it? As doctors, we just can't prescribe food, or we can't necessarily refer patients to the right resources. But I think now we really are seeing just how important it is to capture those data so that we can get our patients the health and the care that they need. And so I think, again, conversations like these are really pushing us in the right direction to try and expand and build rather that connection between health providers, public health, and food resources.
If I could just jump in there, because you mentioned the healthcare and doctors and they can't prescribe food. There are several initiatives that have been starting across the nation where the medical professional will ask a 2-question food insecurity screener. And if indeed it turns out that the family looks like they're food insecure, the physician can prescribe food, and that prescription is taken to an in-hospital or right next to the hospital food pantry, where the family has food that they can take home, and often nutrition counseling there also. So that's getting more and more popular, and I think it's really important.
Yes, thank you for that. Thank you. And for those of you who registered, we do have, you should have received some research documents. If you did not receive those, please reach back out and reply to the email that you got to register, and we'll be sure to send you those research papers. We do have Gary Santel. Gary, thank you for your good work with the Farmers Market Nutrition Program and the WIC checks that are redeemed. Again, those are available for WIC moms and also for seniors to get fresh produce at farmers markets. We continue to see a number of questions and comments about transportation, the inability or the lack of mobility of people to get food. I will tell you there's a trend across this country with food banks in the Feeding America network, as well as with our food bank, that we started to test out home delivery. We have a doorstep delivery program that is focused right now on seniors, and we hope to expand that over the next several years. It was scaled up in response to the pandemic, but this is a program that we will certainly continue on into the future. And in talking to my colleagues around the country, I can tell you a number of Feeding America food banks are also have started home delivery and are looking at expanding that. And also looking at opportunities for people to choose what's in their food orders. So a lot of innovation coming out of the Feeding America network as in response to people's needs. Let's see, we have a question here from Ruth. We have a couple questions from Ruth in terms of getting data that would help your work, that you're collecting data that would be helpful. So you want to receive some data, but you also have some data that you believe would be helpful to share with our panelists. You know, how can we keep this connection from today's panel? We have a lot of people who are interested in both receiving some of your data, but they also feel like they have data to share. What would be the best way to continue this?
Well, we've all, I think, put our emails in the chat. I think, you know, we could work on it in terms of collecting data. You know, hopefully this is the first of many conversations that we have on a local basis. I think the more of us working on this, both in our individual zip codes and sort of on a county-wide and even regional-wide basis, the better. You know, we need as many people as possible. But, you know, putting together questionnaires for the people who are getting food on a regular basis. What do you feel like you're lacking? What would help you make this better? You know, would you use a recipe database? For example, somebody mentioned in the chat, do we see any problems with people knowing how to cook food or even having time to cook food? Would they benefit from, you know, a searchable recipe database? I mean, I think we can brainstorm any number of ideas that would get at what people themselves are really wanting from this. And this has been a conversation that we've had in a number of different ways in a number of different areas. And it's one thing for us to come in and say, you need to eat better, but it's something entirely different for us to go in and say, if you want to eat better, what can we do to help you? And I think that has to be the way that we approach this. And so, you know, collecting that data, getting it individually from people. Are they willing to fill out a questionnaire? Are they willing to be contacted by, you know, researchers who are doing work on this? So, you know, I would love, you know what, flood my email, go ahead. If you have ideas, if you have data. My email's right there. I don't get enough. But being able to get input from as many people as possible, I think is the best way to start. And I know it sounds a little overwhelming, but it's really going to be, I think, the most responsive way. And that's my opinion. Please, other people.
Great, and unfortunately we're out of time, so I want to wrap up now. But as you noticed in the chat, if you did have questions and we did not get to them, we will follow up with you. So thank you everybody for your questions, and we will certainly take you up on that, Dr. Hudson Richards, in terms
I think
of.
I've made a critical error.
Yes, right. Well, my sincere thanks again to our panelists. So thank you to all who joined us today as well. This webinar has been recorded and will be available to you to share with colleagues who are not able to join us today. In closing, I want to encourage all of you to join us for next month for our webinar on building food abundant communities. This session will be led by Dr. Audrey Morell, Board Chair of Food 21 and Acting Dean of the University of Pittsburgh Honors College. It will be held on Thursday, November 19th from noon to 1, and the registration link and invitation to the webinar will be available in the coming days. So thank you again, everyone, for joining us. Wish you the best rest of your day today. Take care.